Welcome, everybody. It's great to see everyone starting to join us today on this very special day for today. Quite a rare disease in our calendar, or a rare day in our calendar. And as we celebrate Rare Disease Day across the globe, we're excited to have you and join our session today. So we're going to start right at 12 as we have another jam-packed day for the second session. So we're excited to see everyone joining, and we'll be starting shortly. Well, I'm going to take a moment to just acknowledge today that, again, it's a pretty rare day that happens in the calendar. And it happens to be a day where we celebrate Rare Disease Day, both the triumphs and challenges faced within the medical scientific community, but also celebrate families and all the work and advocacy they do for the individuals around them and themselves in this community. So good afternoon, everybody, and thank you so much for choosing to be here today and learning about these very important topics today. I'd like to welcome back all of those who have attended session one, either online or watched the recorded link, and gave us some feedback. So we've got some really good changes to what's going to happen in today's session as we look at precision medicine and genetic recommendations after a diagnosis of autism and other neurodevelopmental conditions. So this Follow the Spark series will be discussing actionable strategies to untangle the complexities of autism and other neurodevelopmental disorders. These sessions are hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta in collaboration with the Department of Psychiatry and the PRISMA Research Group, which is Precision Medicine in Autism Research. The PLP creates actionable clinical information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. The PLP is dedicated to moving evidence into practice, fostering a culture and environment where everybody works together to tackle our most pressing problems, advance patient care, and create world-class sustainable health systems, which include important topics such as today. My name is Kelm, and I'm wearing my stripes to support Rare Disease Day. And I'm a research assistant here with the Knowledge Translation team at the Physician Learning Program. I have a Master's of Science in Medical Sciences with a focus in pediatrics. And I've had the privilege to engage and advocate with so many people in the community, with families with complex needs for over 20 years. My work is inspired by these individuals and the many valuable partners in the communities of health, research, social services, and education and policy. As we look to our past and our present, as well as our future, we acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. Before we get started, I have a couple housekeeping points that I'm going to just touch on right now. Please use the chat feature if you have any questions about technical difficulties of our programs and services. If you have any questions for the speakers, please use the question and answer feature of our webinar. And please review what's already been asked to kind of upvote that and make it prominent in the conversation. We cannot guarantee that our panelists will be able to respond to any of your questions, but we will do the best that we can. A recording of this webinar and a PEARLS document with resources will be sent via email to all of those who have registered. Main Pro Plus participants may enter may earn certified credits by completing a linking learning exercise. MOC and Main Pro Plus credits can be earned by completing a personal development activity using my L3 plan tool. And for more information, please use the QR code. The activity has not been formally reviewed by the CFPC or the Royal College. However, eligible credits for non-certified credits is available. And a quick statement on language. While the Office of Lifelong Learning and the Physician Learning Program embraces a language philosophy that promotes an understanding, respect, and inclusivity when discussing autism and other neurodevelopmental disabilities, we recognize the diverse experiences of these communities and strive to use a person-first language, emphasizing individuals over the conditions. We will, however, also be using some medical language and social language interchangeably, as well as they have a role in this conversation. Our aim is to foster an environment where everyone does feel valued and acknowledged. We do see you and recognize the uniqueness and the strengths that each person brings. And we encourage this dialogue, empathy, and continuous learning to ensure that our language reflects the dignity of worth of everyone and every individual affected by neurodevelopmental differences. And on that note, I get to take a quick moment to stop sharing my screen and introduce our main speaker today, Dr. Daniel Moreno de Luca. And I do have a list of where Daniel comes from and all of his accolades, which I can't do it justice, but I will do it as much as I can. So back in 2005, Dr. Daniel Moreno de Luca completed his medical degree from Weiss in Colombia, after which he completed a master's in neuroscience at the Université Pierre de Marie Curie at the Sorbonne University in Paris, France. Dr. Moreno de Luca did a postdoctoral fellowship in neurogenetics at Emory University in Atlanta, Georgia. And then he completed his clinical psychiatry residency at Yale University. His fellowship in bioethics at Harvard Medical School and his child and adolescent psychiatry fellowship training at Brown, where he was an assistant professor of psychiatry and human behavior science since 2018. Throughout the same period, he was also clinical director of the Bradley Hospital of Genomic Psychiatry Consultation Services and an attending child and adolescent and adult psychiatrist at the, I'm sorry, I don't really understand, I don't know how to say this one, but Versailles Clinic for children and autism and developmental disabilities. His current role and new role with CASA Research Chair at the University of Alberta, Alberta Health Services, and the CASA Mental Health, Dr. Moreno de Luca focuses on the impact of genetic variation on brain disorders and how to use his discoveries to enhance patient care. And along with his precision medicine in autism, the PRISMA team, he is in close collaboration with communities he serves, and he aims to contribute to a genomically informed intervention and precision medicine solutions based on his research into genetic underpinnings of autism and neuropsychiatric conditions. So that mouthful is to just say that I truly believe that Dr. Moreno de Luca is a champion for families and individuals, as well as health professionals, in really helping to achieve good health outcomes with as much knowledge as possible. So that being said, I'm going to get back to sharing my screen and welcome you to the stage, and we look forward to what we have here. So before we do get started, let's take a second. We do have quite a bit of an interactive session going on. So if you can hop on and either on your phone or with another screen, So we can find out where everybody is located and give an opportunity to see where everybody is. As we know, Dr. Moreno de Luca has had the opportunity to travel around the world, and we'd love to see where you're joining us from today. So let's take a look and see what we've got here. So if everybody can kind of do a pin on the maps and show us where you're from, we would love to see where everybody is. Oh, we've got some people closer to some Calgary areas. We've got Edmonton. Oh, Peace County, wonderful. I know there's so many rural communities that kind of lack a lot of the knowledge and information and resources that central centers like Calgary and Edmonton may have. And I think one of the things that I know Daniel is hoping to do is to really engage with those communities and build those communities of support. So we have Ontario as well and the territories. This is fabulous. Thank you so much, everyone, for joining us. Now, in recognizing time, we could probably look at this forever as we have quite a few participants today, but we're going to move on to our next slide. But I think we'll readdress this in the end if we have some time. So thank you so much, everyone, for joining us all over Canada and Alberta as well.
Great. So thank you. I'll take it from here. And thank you, Karen, for that very kind introduction. And it's a pleasure to be here with you guys today. And we're hoping to cover quite a few things, and both Karen and myself will try to convey some of those perspectives, but we'd love for this to be interactive and to leave ample time at the end for questions. So this is what we will be talking about, kind of using that Formula One analogy. We'll start on our march, but remembering key genetics concepts and think about how genetic changes contribute to ASD. Then Get Set will highlight the genetic testing recommendations and explore the families and individuals' perspectives about genetic testing. And then we'll hit Go to understand how results have an impact on clinical care and to provide resources for clinicians and families. Next, please. So let's start by bringing together autism and genetics and conceptualizing how genetics is going to contribute towards the etiology of autisms, here with an S to reflect the many different genetic conditions that are encompassed under this diagnosis. So we have this helpful analogy of thinking about autism susceptibility as a jar. We all have these jars, and depending on how full they are, if we get to that autism threshold, then that means that someone would have the cluster of symptoms that will eventually lead to a diagnosis of autism. And there are many different ways that we can fill this jar. So we can fill it with genetic factors and with environmental factors. And with the genetic factors are not all created equal. So on this first slide, we see these purple marbles that are similar to common genetic factors. So smaller in size, they fill the jar to a certain spot, but are not enough by themselves to bring it all the way up to that autism threshold. Next. We can also have large marbles like this one, large magenta marbles, and these would be similar to rare genetic variants instead of the common genetic variants that we talked about. So these ones are much bigger and may have a much bigger contribution towards getting closer to that autism threshold for some people. And in fact, many times, only one of these factors is enough to fill the jar all the way up to that threshold. And then, of course, next, please, we have environmental factors depicted here with the green marbles. And we know that there are several things that can both increase or decrease chances of developing a condition like autism. So some of the typical ones could be very early prematurity or some prenatal infections with pathogens like cytomegalovirus or things of the sort that we know can increase the chances of someone developing autism. And that can be compounded and especially more relevant in the presence of these common and especially these rare genetic variants. So this is how all of these factors come together to develop, to increase the chances of a condition like autism. So on this one, next, thank you. We wanted to know with Karen, in general, how you would rate your knowledge of genetics and your knowledge around precision medicine, knowing that all options are fine. Like, we want to hear from people who do this day in and day out, and from people who are just getting acquainted with these concepts to make sure that we tailor that information appropriately. So like Karen mentioned, if you guys want to join the website in the top, and maybe we can give it 20 seconds or so for those votes to see where you guys are at. Okay. Great. This is fun. Well, you guys are voting. I haven't used Menti all that much, but it's nice to have that direct interaction. And this is really helpful also to think about how to tailor our talk today. Perfect. So we have lots of people who are hearing about some of these concepts for the first time and some who are more familiar with this, and then a little bit less on the precision medicine side. So let's get all of what we need to continue with this talk. And for this, we'll briefly review rare genetics in psychiatry. An ambitious goal, but we'll have all of the building blocks after this slide. So we will be focusing on rare genetics. So I purposefully put that magenta marble up there to remember that that is the category of genetic changes that we will be talking about. So they are rare by definition, meaning that they are present in less than 1% of the population. And when you do see them, like we saw on the jar, they are going to have a big impact on people who carry these genetic changes. Now, these genetic variations or genetic changes can come in different flavors. So they could be an increased or decreased amount of DNA at certain genomic regions. So looking at the total quantity of DNA per regions. And these ones we would call copy number variants, or CNVs. So if a chunk of DNA is missing, we call that a deletion. And if there's an extra chunk of DNA, we call that a duplication. They have to be greater than 1,000 base pairs or 1,000 letters in size. And they can be recurrent, meaning that they happen in the same part of the genome in different people who are unrelated, or non-recurrent, meaning that the breakpoints of where that is happening are going to be stochastic or spontaneous. And those are CNVs, or changes in the total amount of DNA. But we also have changes in the sequence of DNA, and we call those SNVs, or single nucleotide variants. And that would be akin to changing the spelling of a letter in a word. Now, both these CNVs and these SNVs could lead to clinical consequences or not. And we will be focusing now on the ones that do lead to clinical consequences and that are going to have a large effect and that are rare by definition. And next, please. So why is this relevant for psychiatry? We know that autism, and I'll use the word autism and autism spectrum disorders interchangeably, knowing that right now that you can't actually get diagnosed with autism anymore. It has to be an autism spectrum disorder, as it is an all-encompassing term. But for the sake of brevity, autism has a high genetic basis. And we know this because of heritability studies. Now, heritability does not mean heritable, and I wish that I had picked different words for this, but heritability just tells us how strongly genetic a given medical or mental health condition is, and that is calculated among many ways by looking at how frequently identical twins who share all of their DNA are also going to share a diagnosis like autism, compared to fraternal twins who do not share all of their DNA. So the more that the identical twins share those diagnoses, the higher the heritability is, and the stronger the genetic component is. And autism is very high. Now, we also know that these rare genetic conditions, these copy number variants and single nucleotide variants, are not going to account for more than 1 to 2% of cases for each of these variants. But when you bring all of these rare genetic variants together, you can actually identify a genetic cause for autism or neurodevelopmental conditions in up to 40% of people. So this is why we refer to them as being individually rare, but collectively common. And this also means that if you've seen or interacted or heard about 3 people on the autism spectrum, then clearly you have seen one of them, at least, with a genetic cause for their autism. And if you think you haven't seen them and you've seen 3, then they have certainly seen you. So again, this is another point to underscore that many times, because of challenges with genetic testing, this information remains unavailable to families and to the people who may want to use it. Now, the other point that I wanted to get across here is that there is a lot of heterogeneity and overlap, both in regards to the clinical presentation of autism and in regards to their genetic etiologies. So I like to use this analogy with the 3 musketeers and this phrase of all for one and one for all to understand that you can find many or all different rare genetic causes for one condition like autism, and then you can start with one genetic condition and then have a whole host of behavioral manifestations stemming from that one genetic cause. So it could be autism, but also bipolar disorder or schizophrenia, and that highlights all of that heterogeneity and overlap. And then one of the other key concepts for us today is going to be pleiotropy. So because genes have not read our psychiatric diagnostic manual or our DSM, they don't know that they're supposed to only lead to autism or to any of these mental health conditions. And in fact, many times, genetic changes have an effect not only on the brain, but also on different organ systems like the heart or the kidneys. And this is going to be a key entry point for some of these precision medicine interventions. Next, please. Perfect. So this is another way of looking at the information that we were covering. So let's go back to those magenta marbles that we saw at the beginning, and let's put them in the context of the lovely universe of people on the autism spectrum. So everything that falls under this ASD umbrella is that universe. And we can see that there's this beige shadow, and then there are several individually colored bars that are falling in there. So if you look at the area of all of those bars together under the autism umbrella, they're supposed to more or less represent that 30 to 40% of the space that we know are the cases or the people on the autism spectrum who have an underlying rare genetic condition that's leading to their autism. So again, we can identify several of these ones, and we, on purpose, we used several well-known genetic conditions, so we know that these are terms that we've seen all along for decades. And then that encompasses the universe of autism spectrum. But then we can also start with each of these colored bars and then see how likely someone who meets that, who has that genetic condition is to fall under the autism umbrella or not. So we may have conditions like Fragile X syndrome, where a good chunk of people actually are going to fall under that autism umbrella. But then we have other conditions like Down syndrome, where only a smaller proportion are going to eventually meet a criteria for a diagnosis of autism. Now, what I wanted to highlight this is the convergence of that genetic diagnosis on one side and then the behaviorally defined or neurodevelopmental diagnosis of autism on the other side. And I think this is a good point to emphasize that we cannot do a genetic test to diagnose autism. It just does not work because these are different axes. What we can do, and what we'll hear about later in the talk, is that genetic testing is a crucial part and a standard of care for the care of people on the autism spectrum after a diagnosis is made. Because working backwards, you can then identify the causes after you see those symptoms, but it is not going to allow you to predict 100% who is going to develop autism or not, because genetics are not deterministic. And that's a good thing. That means that there's a lot of space for us to be able to empower people to achieve their maximum potential, no matter their genetic background. Next, please. So this is where it all comes together, and we've covered a couple of those different genetic conditions, but I just wanted to highlight this paper as a reference in case someone wanted to delve a little bit more deeply into this, because in addition to those colored bars that we saw under the autism umbrella, there's a whole host of hundreds, if not even thousands, of individually rare copy number variants and single nucleotide variants that are going to contribute to that universe. And they may impact not only the brain, like we said, but also many medical or many other somatic or other organ systems. And next, please. So this is an example of a few of those genetic changes. On the left, you can see where in the genome those changes are happening. So it could be 7q11.23, a duplication in that region. Then we can see the penetrance, or how likely in a population level someone is to develop autism if they have that genetic change. Then we can look at that neuropsychiatric pleiotropy, which just means, in addition to autism, what other neuropsychiatric or neurodevelopmental conditions can someone express if they have this genetic variation. So we have things like ADHD, intellectual disability, anxiety disorders, bipolar disorders, schizophrenia. All of those are associated with many of these genetic conditions. And then on the right, we have the somatic pleiotropy, which tells us about all of the other somatic conditions or medical conditions outside of the brain that may be impacted. So we could have things like obesity or short stature or gastrointestinal problems or heart defects. So all of those are an example of the wide array of potential clinical symptoms that you can see once you start with the genetics spot. And this is going to be key in regards to thinking about how we can put in place precision medicine interventions. Next, please. And next, because this one is just another show of that list that is very long. So why is this relevant? Let's get set. It turns out that there's about 40 million people here in Canada, and we are about 1.1 million of those here in Edmonton alone. Now the population of Alberta is even greater, but for the sake of this example, I used Edmonton as an anchoring point. And the population frequency of autism is up to 1 out of every 36 people. So that's a pretty high prevalence. And we were just learning that up to 40% of people on the autism spectrum are going to have a pathogenic genetic change, CMV or SMV, that is leading to their autism. So even if we use conservative estimates, there could be over 220,000 people in Canada with autism stemming from a genetic cause, and over 6,000 of them here in Edmonton alone. Next, please. So just to let that, to put that into context, that means that there could be more than twice as many people in Canada with autism stemming from a genetic cause as there are people with HIV. So I picked HIV as one of the conditions that is widely, that has a wide array of clinical and research services, to use that as a comparison. So think about all of those resources that are allocated to HIV care. And now think about a population that is twice as large as that one, but that remains mostly invisible because we are not doing the best job we can with testing and with providing those services to this population. So how can we address this challenge? Next, please. We can address it by making that population visible, and the way that we do that is through genetic testing. So how is this happening in the real world? We know that genetic testing is the first-line recommendation from multiple professional societies after a diagnosis of ASD is made. So this testing includes chromosomal microarray and Fragile X, with growing support for exome sequencing. Microarray is going to help us detect extra or missing chunks of DNA all throughout the genome. Fragile X is going to look at one very specific gene, because you need a special technique to pick up the trinucleotide repeat expansion that leads to that you wouldn't be able to pick up with a microarray. And then exome sequencing reads all of the genes in our genome and can also provide us information about extra or missing chunks of DNA. So exome sequencing is eventually and quickly going to replace the other test, and especially with the next stage, which is genome sequencing, that not only reads each of the individual genes, but actually reads all of the intervening space between the genes. That one is really good for also picking up those deletions or duplications and even trinucleotide repeat expansions like Fragile X. So in the future, I think genome sequencing is going to be the one test that allows you to pick up everything very closely, and hopefully exome sequencing, so one step before that one, is going to continue to become first tier. And right now, chromosomal microarray and Fragile X testing are the two recommended tests covered by insurance, by regular healthcare here in Canada, and by insurance in the US as well, and recommended by all of these professional societies. Now, the other point to emphasize here is that our professional obligation is to offer genetic testing and to have the genetic counseling discussions in the clinic and not to do genetic testing. And what I mean by this is that our goal is to empower the families with all the information that they need so that they can make the decision that best aligns with their priorities and their values. So that's a small but very significant clarification that that's what our professional obligation as clinicians is. Now, why do it? We'll hear about this more from Karen, but many of the things that it can help with is that it can provide an etiological explanation and in the diagnostic odyssey that many families go through. It can allow us to have better recurrence risk estimates and family plan and empower families to make family planning decisions based on that information. It can connect families with other families with the same genetic variant, in a way opening a secret door that families maybe didn't know was available for them before, and obtain that sense of community and know that they're not alone in the world, as many families sometimes feel. And it can also alert about potential medical co-occurring conditions. Next, please. So we know that this is what should be happening in the real world. What's actually happening? We wanted to answer this question, and we looked at the Rhode Island Consortium for Autism Research and Treatment, which is a very large autism study where I was at before at Brown University, with over 1,800 participants from the smallest state in the US, Rhode Island. So it gave us a good sampling of the population there. And we know that the frequency of those conversations should be 100%. And let's see how that was faring out. So next, please. Not too great, unfortunately. This is a little bit of a downer slide because we found that only 3% of people reported having had the standard of care testing at that time, which is, and still is in many ways, microarray and Fragile X testing. So there is a dramatic gap to fill to implement those recommendations in clinical practice. Now, this study was surveying all of the population that we had recruited for that study in Rhode Island, including some who were seeking medical attention and some who weren't, so that it would explain some of these. And it would include people who were diagnosed within psychiatry, pediatric neurology, developmental pediatrics, just general pediatrics, primary care, internal medicine, so a whole host of different specialties. And one of the areas, one of the specialties where we need to do a much better job is our own, is psychiatry and child psychiatry. So I think the landscape could be a little bit different if you survey, let's say, developmental behavioral pediatricians, because that is more part of the discussions of those encounters. But in child psychiatry and in psychiatry, even more so in adult psychiatry, we still have a long way to go. So we need to implement a large-scale effort to bring those recommendations to the clinic. So the first step in doing that is to understand why this is not happening and what we can do better. Next, please. So we went to the most important place first, which is the families and the individuals with this diagnosis themselves, to see what their attitude, perceptions, and results about genetic testing was. We did a large survey within that same population where we had over 240 responses, and we learned from the families that they were familiar with basic genetics concepts, but not so much with the specific terms. And they reported that the majority of them had not been offered genetic testing by their medical team, but when they were offered, 91% of them agreed, and 27% of them had an abnormal result, which is in line with that 30 to 40% that we were expecting to see. So I really like this 91% number because it tells us that families are very supportive of this and they want to have this information available to them, but it's also not 100%. So this tells us that there are some families who will elect not to move forward with genetic testing, and that is key because our role is to support and empower families to make those decisions and not to impose our own decisions either for or against genetic testing for these families. Next, please. Now, once we have that information, how could we bring that to the clinic? How could these rare genetic variants of large effect inform clinical care? Our argument is that this is possible now with readily available resources by modifying treatment algorithms to include clinically actionable interventions. So lots of fancy concepts in here, but the point is that we don't have to wait around until gene therapy or all of these other interventions like antisense oligonucleotides, which are really exciting, come to the clinic. They may be years away, but there are many things that we can do by putting on our clinician hat and being aware of this pleiotropy and finding those opportunities to enhance care. Next, please. And we would do this by first bringing all of that evidence together and then looking at the clinical management guidelines for ASD and other psychiatric conditions to identify decision points where that genetic information could alter clinical management. So we like to call this the actionable genome, similar to examples that have happened in cancer, but still much farther behind than what's actually happening in cancer. And the entry points for this actionable genome could be by thinking about susceptibility to specific medication side effects or pharmacological or behavioral treatment based on the underlying biology or prophylaxis of co-occurring conditions and many others. So this is not pharmacogenetics, that's a different field, but this is how do you leverage getting to know the patient in the clinic much better and knowing their challenges, but also their strengths to tailor treatment when they need it. And in the interest of time, I don't have specific examples of this, but hopefully this is something we can cover in the Q&A. Next, please. So to implement this, we've created several clinical services here as well within our Edmonton and within our Alberta ecosystem. And we have two main ones that are the Genomic Psychiatry Consultation Service, where we aim to provide these actionable recommendations for people who had genetic testing and who have an abnormal genetic result, and to provide additional tools for the primary physicians to manage these patients. And these primary physicians could be other child and adolescent or adult psychiatrists, pediatricians, developmental pediatricians, neurologists, internists, or family docs or PCPs. So we have a lot of collaboration in that space. And then we also have a service called the Genetic Counseling Service that we developed and we recently opened, specifically focused on talking about genetic testing and carrying that out for families who agree to have that done. So we can help our clinical colleagues and the families in our community increase the uptake of this genetic testing if that's what they so choose. So this is just a quick algorithm of how those services work, and they're both ongoing, open, and available here at the LMD clinic. Next, please. We're also very interested in providing resources for families. And one of the things that we were hearing directly from those surveys was that there was limited knowledge about genetics, not only from the families, but from many of our colleagues in psychiatry and in other specialties. So we developed an animated video that goes over everything we need to know about autism, genetics, and genetic testing. And of course, that's a little bit of an exaggeration, but it's a really good anchor to start a lot of those discussions around genetic testing in the clinic in a way that's co-developed with the autism community and friendly for kids and adults alike, and in a way which could also be even a stealth intervention for clinicians in our team, because they see this with their families, and after seeing it for 10 times, maybe they feel a little bit more empowered to have those discussions themselves. So we can play 10 seconds of this video just so that you get an idea of what it looks like. Welcome to the Prisma Library of Life. We've been expecting you. I'm Bo, and I love discovering new things and places. This is my close friend Dina. She's very curious and wise. Our favorite thing to do is to help people read the wonderful books we have here and explore all of the very special objects in this place. Next. That book? Excellent choice to start. Karen, can you move on to the next one so that I don't take up all of our time? Let's dive in. Perfect. So if you're intrigued by that video, it's freely available in YouTube, in our website, in English and in Spanish, and very soon in French. So feel free to disseminate that and use it as widely as you want. And I think this is also a good time to transition into Karen's side of the presentation, because one of the things that we want to come away with is that we want to find ways of celebrating this difference and to empower the community to be the best version of themselves that they can be. So a lot of the conversation, in my view, unfortunately, hovers around deficits, but there are many challenges, and there's this wonderful world of neurodevelopmental differences and of autism spectrum that we want to celebrate, and we want to allow people to inhabit that space as they are, building on those strengths as well. So I think with that, I'll pass over the baton to Karen, who can share a little bit more about her work, and then we'll have some time for questions.
Wonderful. Thank you so much, Daniel. And I think what I appreciate a lot about your work and the vision that you have is this balance between focus in science and families, and really acknowledging the challenges, but also illuminating the strengths. And so while your library of learning is really those chapters of how can we support families, and really focusing on the benefits of a diagnosis really adds to that chapter as well. And hopefully by sharing this understanding of family experiences will provide individuals who are participating in this conversation and those around us to really see what actionable strategies that we can use to support families going forward. And so a little disclosure to add to this as well is that myself, I am the president of the Fragile X Foundation of Canada, as well as a parent with three of the most amazing kiddos diagnosed with Fragile X. So they definitely guide my work and my subjectivity when I bring it in and what we can do. So that being said, when we look at the umbrella of autisms that Daniel was explaining, and we get to do a little bit more interaction, so grab your phones or your other screen and log into Mentimeter. And, I think I did see a comment in the chats about FASD, and there's other diagnoses around neurodevelopmental disorders. And it's challenging because there's quite a few. And I get the opportunity right now to share with you about Fragile X when there's many other diagnoses out there that don't necessarily get that attention. And I do recognize that and acknowledge that. And so that being said, I'm curious as to, what is your knowledge and your experience when it comes to Fragile X syndrome. So if we take a look at our next slide here, and before we go into anything, I'm curious as to, what is your knowledge of Fragile X? What is, and if you're confident in your abilities, if someone were to enter your practice or support, acknowledging that we have primary care specialists and allied health professionals attending today, do you feel prepared to be able to support families? And we can see that there may not be a lot of preparedness with what we're doing and knowledge, but hopefully maybe what we can do is change that by saying sometimes we don't necessarily need a diagnosis or knowledge of that diagnosis to go forward and support families. And so that being said, I could talk for hours about what Fragile X syndrome is, but I think a basic understanding is it is an X-linked dominant disorder and the most common known single gene cause of intellectual and developmental disabilities, and autism spectrum disorder. And it's quite an interesting one, especially to talk to on Rare Disease Day, because as a parent, having your child or 3 children diagnosed with a rare disease, it doesn't seem rare in your world. And so when Daniel was talking about those benefits of diagnosis, I thought it was beneficial within a family perspective to understand why those are why a diagnosis is so meaningful. And many of you may have heard of the diagnostic odyssey, which is typically this length of time and uncertainty that families face when receiving until they receive a diagnosis. And some families are even still waiting for those chances to have that opportunity. But once a diagnosis has been received, we can see how there's a change in families. They've finally been given some information. They have knowledge, and it might be on things like management and treatments and prognosis. It may not be in rare disease, but really it gives families an opportunity of hope because they have some answers to build those chapters, and it gives them a direction to go in what they can start tackling instead of living in uncertainty. And if we look at kind of those reoccurrence estimates and family planning, we also realize that it has to do as well with future planning and family telling. And so what I mean by that is it's future planning in, what are the opportunities for my child growing up? And not necessarily limiting it to what research says, but giving the kids the best opportunity to, hit the clouds and achieve all that they can. And then we're also faced with telling our families, what does this mean to have this genetic disorder in your life? And potentially a lot of families are the first to know this. And so they're sharing news within their family for the first time as well. And so Daniel touched on this and how, receiving a diagnosis really helps families connect with families within the same environment and the same variant that they have. And this is so meaningful. I look at in the Fragile X world that I live in with my 3 kids, there's 2 different ways in which we can interpret having a Fragile X Day. One is celebrating World Fragile X Day and really connecting with a global community. And 2 is just sometimes parents really struggle, or they're having a down day. Maybe they're having an up day. And it's really something that maybe another family experiencing Fragile X may understand in a better context than someone else. And someone to hold space with someone who understands and can just nod their head and acknowledge the challenges that they're having, as well as providing tips, tricks, and strategies that might not be typically out there. I know in our world, we have a lot of self-care issues with our older children or our older child. And sometimes it's sharing things like have a bag of rubber gloves in your bathroom to help with self-care. And those things are life-changing sometimes for families. So while we are waiting for targeted treatments and support in those ways, sometimes a rubber glove and a wipe in the bathroom changes the whole dynamics and perspectives going forward. And attending conferences and connecting with more families as well. And we talk about potential medical co-occurring conditions. Sometimes within a rare disease, within Fragile X, there's connective tissue issues, epilepsy, and other medical conditions. They might not be prevalent within the entire population, but it gives families something to investigate, something to learn about and prepare for, so that if something were to come up, they're not surprised by it and they know how to support the individual as well. And I kind of added another one in planning these sessions when we can talk about how a diagnosis sometimes explains the unexplained. And again, for a lot of these, I'm talking in generalities, which is sometimes what we need to do to give a basic overall understanding, and everyone's journey is quite unique. But when we compare autism and Fragile X, we can see how there's many different, a lot of similarities, but a lot of differences. And I've seen that within my children, and where we sometimes struggled with getting a diagnosis, where social interaction is something that individuals with Fragile X strive for, and it gives them meaning and purpose and belonging. But it may not be something within the autism community that's embraced, as well as behavioral challenges. A lot of times behavior within Fragile X is for different reasons than we see within the autism community. And so finding these differences and similarities are really important in that journey. And so once this diagnostic odyssey is complete and individuals and families receive their diagnosis, it starts this labyrinth of supports and knowledge and learning. And really, it's this guiding principle where, families really become the forefront of advancing rare disease research, innovation. They tirelessly advocate for awareness, funding, scientific breakthroughs to improve an understanding of a diagnosis, and treatments as well. And so this is because a lot of the common disorders out there have this information already. And the very small and heterogeneous population within rare disease, parents are really at that forefront of investigating all the needs of caring going forward. Now, we don't really have too much time because I want to be able to get to questions. But one of the questions I was going to ask was, how do you feel about responding to families who approach you with potential interventions? And it kind of goes to our previous slide that we were talking about, because a lot of times, and for example, a medication right now in Fragile X syndrome is metformin. And while that's most common within the diabetes community, it's not something that's familiar with Fragile X. And so I was curious to see kind of how people would feel with information coming in. And my response to you would just be, listen, hear, investigate. And I do acknowledge that within both the health and the family community that we're beyond capacity at this moment, but listening goes a long way. And so after a diagnosis, we also have this opportunity to see beyond a phenotype. And so these are my three amazing children, Noah, Sydney, and Ty, who I'd love to get into a case study and kind of give you how they present within the Fragile X world, but it's so unique and diverse in each of the three kids. But we need to see beyond what is advertised out there within Fragile X and all the deficits. And we need to really start looking at who these kids are and what they are. And they are athletes. They're joyful, they full of empathy and thoughtful. And in our world, we're so excited because the newest word that we get to bring in is college student. My daughter just got accepted to college. And so this goes back to the first couple of slides where we talk about hope and we don't focus on those deficits, and to give families something to strive for. And so as we begin to wrap this up, I just wanted to share with you some insights on how you can be a champion to families. How can you have those conversations with newly diagnosed families to really give them care and support in a meaningful way when maybe there aren't targeted treatments available? It's not a matter of doing all of these things, but finding a couple that you feel comfortable with doing, whether it's care coordination and planning. We have a lot of primary care providers attending these sessions, and it's building those long-term relationships, because a diagnosis isn't cured once a child hits adulthood. These diagnoses last with these individuals for a lifetime, and having that consistency in care is very important. And then if we look to experienced families, someone who's been down the road forever, how can you be supportive? It's really acknowledging the expertise that these families have had in the diagnosis, as well as the care of their child, and provide feedback. For the longest time, families are always seeking out information and finding supports. Sometimes they just want someone to tell them what to do as well, and support those mental health and recognize the load that families carry and in support. And if we look at that jar that Daniel had presented in his sessions, we can really see all the different pieces that make up these wonderful human beings, and how important it is to really acknowledge those challenges, draw upon the strengths, understand the deficits, but really say to yourself, you're challenged in this, but what are you good at? And find out who these individuals are as a person and see them, and how can we help them, and give parents hope and something to strive for, and not just something to manage. And Daniel, I'm going to pass this over to you as we wrap things up and take a moment for questions. And before we do that, I know the session was going to 1 o'clock. Daniel did mention that he has a couple moments after, so we will be able to continue it, but we do want to wrap up by 1 just to respect everyone else's time.
Thanks so much for sharing that, Karen. And then I'll very quickly just go over our conclusions, which are exactly what we set off to say at the beginning with the outline. So hopefully today we were able to remember some key genetic concepts and review how those genetic changes can contribute to ASD. We also highlighted the genetic testing recommendations, and we explored the families and the individuals' perspectives about genetic testing. And then we tried to understand how those results could have an impact on clinical care and in community, and provided some resources for clinicians and families, including the lovely presentation from Karen from that perspective. So we got to that checkered flag. Hopefully we were able to convey this. I know it's a short amount of time, but like Karen mentioned, the seminar will end at 1, but we'll be around if there's any lingering questions and anyone wants to stay a little bit longer for that. So thank you so much for everyone for coming today, and we look forward to getting into those questions and connecting.
Excellent. And for those of you who do have to run, we would really appreciate your feedback on these sessions. I know on session 1, a lot of our feedback was time. I wish we could block off an entire day and have conversations about this, but your feedback helps us in really planning for the next sessions, and it gives us an opportunity to support you down the road. And if you take a look through these evaluations, we have also set up an opportunity for you to be a part of a draw for a Starbucks card by entering out the feedback evaluations, which will take place 1 week from today. So if you have a moment, that would be great. And then this is a 4-part series. So if any of you have not registered for our upcoming 2 sessions where we can navigate across a lifespan, as well as a panel discussion. So these have been cut really tight, close to the end. So the panel discussion gives an opportunity to reach out again to Drs. Wagenbaum and Dr. Moreno de Luca, and our other panelists going forward. So I will leave that up there. Thank you again, everyone, for attending. We will be sending out a recording and everything going forward. So that being said, I'm going to hop onto the chat, and we've got some really great opportunities to have discussions going forward. And one of the questions I can see in the chat is, and Daniel, I'm going to send this one to you to start, is how do you support families for whom genetics does not yield a diagnosis? Okay. So are there any stats for that?
Yes, so great question, in the sense that the absence of a genetic diagnosis is still the presence of new information that we didn't have before. So many times we think, oh, we didn't find anything. We did find something. We found that there were no genetic contributors in this particular case. So then that allows us to know that there are certain areas that we don't have to keep surveilling super closely. We have that extra information. And thankfully, we have robust supports that are still not enough, but that we're hoping to build up in collaboration with all of our partners to support those families. So the supports would be similar to the ones that everyone else with either autism or other neurodevelopmental conditions would have in regards to going by symptoms. I think it's important to know that the majority of times when someone comes to see us in psychiatry is not because of autism, but because of some of the other conditions that very often go along with autism, where we can intervene. So we never really intervene only in the autism space, as we consider this a different way of just being in the world. But we do offer help with ADHD, anxiety, depression, or some behavioral outbursts, or some behavioral strategies and pharmacological strategies when issues arise. And knowing that we already did the genetic testing, and even if we didn't find anything, that is helpful information to inform, sorry about the redundancy, that management as well.
Excellent. And I think, so I'm going to throw it out there too. So it is 1 o'clock. So thank you everyone who has joined us. Also, feel free to raise your hand if you do have a question. I can't remember if we can unmute and ask questions, but again, please use the Q&A for any questions that you do have. Daniel, I have a question for you. I think there's a couple comments in the chat from what appears to be a parent, and I think being a parent myself as well, is, we create this booklet essentially of everything that we're seeing with our child, behaviors, challenges, successes, everything. What do you recommend to parents that may be attending this session, and how can they have conversations in a meaningful way with their health professionals so that they can feel listened to, and maybe even go down the route of genetic diagnosis if that's not happening?
That is so important, and I think that is one of the things we emphasize at every appointment in our clinic. Like, I wish we had a criteria that was parental gut feeling, because that is extremely valuable information. You may get specialist physicians in psychiatry or neurology, but I mean the parents and the families are experts in their own child. So there's a lot of insights, and it makes me sad to hear that sometimes that information does not get across. So whatever you guys can do, and I think a lot of the onus is actually on the healthcare system to allow those voices to be heard more clearly and more loudly, but just making sure that you connect with your clinical team and that you have enough time and that you feel heard, and finding ways of advocating for your impressions and not shying away from bringing something up. Like, the clinical team is there at your service and to resolve the questions that you may have. So in a way, you call the shots about that. So I would encourage you to make good use of that and not be shy of bringing up your questions, and that is the place where you should have all of them resolved.
Excellent, thank you. I have to pop off the screen for one quick second, but while I do that, could you answer the question that's in the chat about, is it helpful to get genetic testing done in the early years of getting a diagnosis, or done at any time point? Mm-hmm.
So at any time point, the earlier, the better, just because we have that information a little bit sooner in the kiddos' lives. So if there are things that we need to address, we can do that earlier. But there's no cutoff window where someone turns 18 and they no longer can benefit. There is still information to be gained, and it continues to be part of those recommendations. Like, I say this jokingly, but I think it gets the point across that a 17-year-old on the autism spectrum turns 18, and it's not like it magically becomes a new person with a different life. It's the same person that just went to bed and woke up the following day. So all of those recommendations continue to apply, even though I fully acknowledge that the legal and that the support landscape changes dramatically overnight. But in regards to genetic testing, those recommendations are throughout the lifetime if that has not happened before.
Well, and I think as a family too, those answers help and kind of that life library. Families are building their library of knowledge. And so every piece of information they get is so powerful. And I think, I've heard conversations sometimes where a rare genetic diagnosis is sometimes ethically questioned as to whether we do it because of targeted treatments. And I think for a lot of families, that they're not necessarily going for the targeted treatments. They're going for answers to just help build their library of knowledge that you were talking about. So we do have a question in the chat as well about ADHD being quite common, and also seeing it more within clinical practice in collaboration with an autism diagnosis. And a very large percentage of patients with ADHD struggle with executive functioning. Are there any data on genetic testing on ADHD?
Yes, and I think first it's important to emphasize that concept of pleiotropy that we were reviewing, and that applies also to neurodevelopmental manifestations. So a lot of kiddos on the spectrum are also going to have ADHD. A lot of kiddos with different diagnoses are going to meet criteria maybe for anxiety. If you look at these diagnoses in isolation, which is not the most frequent presentation, so if you look only at people who have ADHD and no other mental health diagnosis, then that is also a strongly genetic diagnosis, but less so than autism, for example. And because of that, the recommendations for genetic testing that get triggered within the autism or intellectual disability or global developmental delay space, those three criteria, don't necessarily get triggered yet for ADHD in isolation. What happens is that if you have a kiddo or an adult with several of these symptoms, maybe ADHD and ASD, and you do genetic testing, that result would explain not only the autism, but also the ADHD, and also maybe some GI issues and some cardiac issues. So once those features are present, if you find an explanation, it is extremely likely that it is going to explain the entire cluster of clinical features that someone may have. But as a standalone ADHD test, genetic test, we are not there. And I'm not sure that we will necessarily get there based on the genetic contribution to ADHD being significant, but smaller compared to autism and other neurodevelopmental conditions.
Excellent. I think we have a couple overlapping kind of questions. So the first one being, are these tests covered by Alberta Health Care? And in conjunction, do we test? Oh, we'll get you started on that one. So are these tests covered?
Yes. Very quick and easy answer. This is part of standard clinical care. We're talking about genetic testing that is supposed to benefit individuals and families directly. Although research is really exciting, this is not research. This is ready now for clinical prime time and covered by insurance. So both chromosomal microarray and Fragile X testing are covered by AHS, and exome sequencing can be covered eventually as an out-of-province test for a select number of people. Let's say that they test negative before and they have a much more severe presentation that may involve seizures or other medical comorbidities. In those cases, exome sequencing also gets approved for coverage. So yes, this is part of the clinical work.
And having a lot of primary care providers attending these sessions, how would someone within a private practice refer a family for genetic testing?
So we have plenty of avenues to get to genetic testing. If you're in Edmonton and the presenting symptom is psychiatric or neurodevelopmental, we're happy to see them ourselves at the L&D clinic. We have that genetic counseling service and we have referral forms. Our wait list is not super long, so we would be happy to help with that piece. And if the presenting symptoms are not neuropsychiatric, but maybe physical, like a cardiac problem, then you guys can go directly through the medical genetics team here at the U of A. And in Calgary, there's also a very strong medical genetics team. We are hoping, and we're actually able now to offer these assessments as telehealth as well. So if we can help, the idea is that we're coordinating services between all of our teams to enhance the uptake of these discussions and potentially genetic testing for families who agree to move forward. A quick disclaimer is that as of now, as I understand the provincial landscape, these genetic tests can be ordered by specialist physicians, and I'm not sure that family docs are there just yet, where we want to develop the infrastructure for that to happen in those family doc appointments. So hopefully we'll get a little bit of traction, but right now family docs would have to refer and specialists can order the test themselves. We're happy to receive referrals from any of those sources, and we're also happy to support specialists who want to do the test themselves.
Excellent, thank you. I think we'll hit one more question, and then I think we'll call it. But again, if there's anyone still here that has questions, or feel free to reach out and join our other sessions. But we do have a question in the chat about do we need to test female child for Fragile X? And what about Rett syndrome? And so I guess that would be when someone submits an overall genetic testing, are they selecting specific ones, or what does that look like?
So very briefly, the chromosomal microarray test looks everywhere in the genome. So that one, you select that test, but it's looking everywhere. And like we said, Fragile X needs to be more tailored because of the specific genetic nature of Fragile X. What we didn't say is that it's kind of obvious, but the Fragile X gene is in the X chromosome. Biological males only have one X chromosome, biological females have two, meaning that it is much more likely to find a diagnosis of Fragile X in males, because if you have a change in that gene, you don't have an extra copy that would be present in the other X chromosome for biological females. Now, what happens, and what we didn't review, is that there's a process called X inactivation that happens in all biological females. So in each and every one of a biological woman's cells, there's only one X active at a time. And that can be active, like that activation is at random. So in about 50% of the cells, one X is active, and in the other half, the other X is active. So many times, if that split is 50-50, so one X in 50% of the cells, then you don't get to see symptoms of any conditions that are associated with changes in the X chromosome. But if you have what we call skewed X inactivation, meaning that you preferentially inactivate one of the two X chromosomes, then conditions like Fragile X syndrome may arise in biological females. And the impact of that is going to also depend on the degree of X inactivation. So, for example, you could have a biological female with Fragile X syndrome that presents very mildly if they preferentially inactivated their non-mutated chromosome in 60% of their cells. But it could be much more severe if they inactivated their non-mutated chromosome in 85% of their cells, for example. So that is one of the factors that is going to come into play. And this answer is also very helpful when thinking about Rett syndrome. So Rett syndrome used to be covered under that umbrella of autism spectrum disorders back in the day. It's a specific genetic change, genetic condition caused by mutations in the MECP2 gene, which is also on the X chromosome. So everything that we talked about for Fragile X also applies to Rett syndrome, except that if it's caused by a missing chunk of DNA that includes that gene, you would be able to pick that up with a microarray. So about half of the cases or so are caused by a deletion on that MECP2 gene, and some others are caused by point mutations, so spelling changes in that MECP2 gene. So you may pick that up if it's caused by a deletion with a microarray, but not if it's caused by a mutation. And then the same thing is going to play, except that the impact of changes in MECP2 is much higher than the impact of changes in Fragile X, in the sense that it tends to be lethal in biological males. So the majority of people you see with Rett syndrome caused by MECP2 mutations are due to mutations in that gene, and only having one of the two copies impacted in biological females is going to be, well, don't know when that came about, that is going to be enough to develop a condition like Rett syndrome. There are very rare cases of biological males with Rett syndrome, but that is highly unusual. And you should be able to pick up about half or so of the people with Rett syndrome with a microarray, and all of them with an exome sequencing.
Excellent. Well, thank you so much for your time, your wisdom, your insights, but most importantly, I think your care and compassion for all of this, Daniel. We're so thankful for everyone that's been here today. Hopefully we'll see you next week, if not the following week, with the panel discussion. So feel free to come there with lots of questions and opportunities to get some of those questions, learn more, and collaborate with other people. So thanks again, Daniel, and I look forward to continuing this conversation.
Likewise. Thanks so much, Karen, and everyone for being here today. And please reach out if there's any lingering questions.
Cheers. And thanks for celebrating Rare Disease Day with us today.
Yeah, that was what the balloons were about.
Maybe. There you go. Excellent.
Nice to see you.
Well,
Bye,
cheers.
everyone.
Thank you so much.
Bye-bye.